Very good afternoon to Associate Professor Dr. Ahmad Khaldun Ismail, our panelists Dr. Emilia Santamaria, Dr. Yor Blessman, and Dr. Miat Tet Neo, clinicians and fellow medical students. My name is Putri Nur Anissa, and along with my friend Wan Abdul Aziz, final year medical students in University Kebangsaan Malaysia, currently in emergency medicine posting, will be moderating today's webinar and forum.
Welcome to the second series of Clinical Toxinology webinar organized by the Emergency Medicine Department of the Hospital Chancellor Tuanku Mukris in collaboration with the Malaysian Society on Toxinology, Remote Envenomation Consultancy Service, College of Emergency Physicians Special Interest Group in Clinical Toxinology, Malaysian Biodiversity Information System, University Science Malaysia National Poison Centre, and University Science Malaysia National Poison Centre. In this webinar and forum, we aim to explore the topic of clinical toxinology. Is it relevant to medical students?
To deliver a welcoming remark, please join me in welcoming Associate Professor Dr. Ahmad Khaldun Ismail. He's a consultant emergency physician, the founding consultant and advisor of Remote Envenomation Consultancy Services, and founding director and advisor of the ASEAN Marine Animals and Snakes Envenoming Management Symposium. He is a member of the WHO Global Roster of Expert and Technical Advisory Group on the Prevention and Control of Snakebite Envenoming. He's currently an honorary visiting scholar at Graduate School of Medicine, Tohoku University, Sendai, Japan, honorary consultant at the National Poison Centre, University Science Malaysia, and a resource person at the Malaysian Biodiversity Information System, Ministry of Energy and Natural Resources. He was the president of the Malaysian Society on Toxinology from the year 2013 to 2021, and a review advisor for the WHO Snakebite Envenoming Working Group from the year 2018 to 2019. His special interests are in clinical toxinology, emergency medicine, and pre-hospital care. He founded various educational programs related to clinical toxinology for the public and healthcare professionals. He is passionate about teaching and is frequently invited as a speaker in Malaysia and internationally. He holds the authorship of several academic publications in related areas of interest.
Ladies and gentlemen, joining us today, we are very grateful to have the panel of experts. The first one is Dr. Miat Tet Neo. Dr. Miat Tet Neo is a medical doctor with over 14 years of working experience in public health area in Myanmar. As she was born in tropical country where snakebite is common yet one of the neglected public health issue, she has a high interest and strong enthusiasm in working and improving the management of snakebites. Till date, she has involved in several snakebite related research activities, including Australian DFAT Myanmar Snakebite Project, where she worked as a local project manager. She also has involved in planning and implementation of a snakebite clinical trial research, which aims to determine the optimal dose of antivenom for Dobia siamensis envenoming. She worked as a liaison officer as well as a research coordinator for sustainability of the snakebite project outcome at Non-Communicable Disease Control Division at Ministry of Health and Sports, Myanmar, for about 2 years. Aside from snakebite project, she also worked in INGO in a different position with main focus on communicable disease such as tuberculosis, malaria, HIV, STI, under 5 pneumonia, and diarrhea prevention and treatment. She has contributed to a number of publications in high-impact international peer-reviewed journals as well. She is passionate about training the young researcher and healthcare staff in snakebites-related activities. Sightseeing, hiking, and gardening are her favorite pastimes.
Okay, moving on to our next panelist, which is Dr. Yor Blessman. He's a medical doctor specialized in internal medicine, infectious disease, and public health, and works as a postdoctoral scientist and head of the research group Snakebite Envenoming at Bernhard Nock Institute for Tropical Medicine in Hamburg, Germany. The main focus of his work in the field of toxinology is epidemiology of snakebites and the respective snakes, clinical studies, training of medical doctors and nurses in management of snakebite envenoming, and community education in the Laos and Vietnam, in Southeast Asia, in Ghana and Gabon in Africa.
Our last panelist is Dr. Emilia B. Santamaria. Dr. Emily is an emergency medicine consultant, founding member of Philippine Toxinology Society, member of Remote Envenomation Consultancy Service ASEAN, member of EMS and Disaster Medicine Committee, Philippine College of Emergency Medicine, member of Health Emergency and Disaster Study Group, National Institute of Health, University of Philippines, and associate member of Pan-ASEAN Resuscitation Outcome Study and Pan-ASEAN Trauma Outcome Study. Clinical Research Network Philippines. Currently, she working at University of Philippines. Her research areas of interest are emergency medicine, toxinology, which is neckbite and marine environmental management, EMS and disaster medicine, and also public health. A warm welcome to our panelists. Thank you for joining us today.
So moving on to our pre-webinar survey. So this is the survey that we have given to a group of medical students in the emergency department currently. So we asked if they're actually aware of the clinical technology, and it's about half knows about it and half doesn't really know about it. So we actually look at their awareness, confidence, and knowledge. And majority of the students are actually neutral, or they're actually not aware, and they're not really knowledgeable regarding this topic. So hopefully by the end of this webinar, we become more knowledgeable from here on.
Next up, we'll provide a brief introduction to our fellow final year undergraduate medical students on the topic of clinical toxinology. What is a toxinology? Toxinology is a scientific study of substance produced by living organisms, either delivered as venom or otherwise, residing within the tissue of animal, plants, mushroom, and bacteria, and which may harm the target organism, mainly focused on toxin. How about clinical toxinology? Clinical toxinology is an area of specialist medical expertise that they are dealing with envenoming and poisoning caused by animals, plants, mushroom, and bacteria. However, for our my colleagues, we should not confuse with toxinology and toxicology. It's a two different thing. Toxinology, just as explained just now, is a substance produced by living organism, such as a venom, especially venom. However, in toxicology is a field of science that help us understand the harmful effect of a chemical or substance that can have on people, animals, and environment. It's mostly covering the broad spectrum of substances such as pharmaceuticals and industrials and agriculture chemicals, as well as animal, plant, and microbial toxin and their effect on living organism. How we differentiate between envenomation and poisoning. Envenomation is the exposure to venom contains toxin resulting from venomous animals. However, poisoning is the administration of poison containing natural toxin inside one body via swallowing, inhalation, or absorption through skin. How we differentiate between these two is easy with this particular words, sentence is, if you bite it and you die, it's poisonous. If it bites you and you die, it's venomous. So it's easy for my colleagues to help understand it. There's several group of clinical toxinology in Malaysia, which most of our prof really active in it, which is a Malaysian Society on Toxinology, and most of our panelists was one of the consultant in the remote envenomation consultancy service, especially in ASEAN area. Clinical Toxinology Special Interest Group, College of Emergency Physician, Malaysian Biodiversity Information System, and also University Science Malaysia National Poison Center. So what is importance of clinical toxinology for medical student? For the first thing, as a medical student in Malaysia, envenomation is quite common in Malaysia because we have a lot of snakes in our country. We also have a few others toxin animals in our country. And toxinology is is a emergency care, and it's a life threatening to the patient.
So next up, we'll have 5 case presentation, and after each case, we will invite the panelists for some discussion, and followed by a short Q&A session. The audience can drop their queries in the chat box during each case presentation. So now let's kickstart with our first case. So this is the history of a 28-year-old Malaysian male, alleged snake bite over his right ankle. Incident occurred around 7 o'clock on 23rd December 2023 at Padang Sawit Kungkung, Pasir Gudang, Johor. Patient was collecting palm oil from the ground alone. Suddenly, he felt the bite over his right ankle and noticed a shadow of small snake length around 15 to 20 centimeters. In view of darkness at the time, he was unable to describe the features of the snake and unsure of the color. He was bitten one time and the snake ran away. Post-incident, patient has minimal bleeding over right ankle associated with pain over the bitten area and numbness all over the right lower limb right after the incident. The pain score was 5 out of 10. He was still able to ambulate back to his house, and which is around 30 minutes away from the estate. At at home, there was no more bleeding. He claimed his friend helped to massage with minyak angin over the right lower limb and apply over the bitten side and tried to squeeze out the toxic inside. He noticed only clear serous discharge. However, around 9 p.m., patient developed numbness over the oral and facial with breathlessness. Thus, he went to the ED in Hospital Sultan Ismail, Johor Bahru. So at the ED at 9:57, patient's GCS was full, 15 out of 15. However, noticed slurred speech, gag absent, pupils were over 4 dilated with diplopia present. Otherwise, patient was not tachypnic, not in respiratory distress, and afebrile. So his vital signs were his blood pressure was a bit hypertensive, heart rate was normal, oxygen was 100%, temperature is normal, and respiratory rate was also normal. And for his examination towards his respiratory, cardiovascular, and abdomen was all normal, and there was no other puncture marks seen. Okay, so for the local examination from the picture here, we can see there's actually 2 bite marks seen over the lateral of right ankle, but there's no swelling, no skin changes, no blackish skin, or there's no discharge seen. The distance between the puncture wound, however, was 1.3 centimeters. Dorsalis pedis artery and posterior tibial artery were palpable. The range of motion of the ankle was full. Capillary refill time was less than 2 seconds, and it had warm peripheries. So for the investigation that was done, majority of the investigation were normal, but the one that we could highlight here actually is the urine toxicology, which he was positive for amphetamine and methamphetamine. So from that, at the ED, he was actually given IV neuropolyvalent antivenom, 5 vial, ran over 50 minutes. He was also given IV drip for 4 pints, normal saline over 24 hours, IV hydrocortisone, 200 mg stat at midnight, IV Periton, IV Tramadol, and IV Maxolon. So the impression from this case is actually an alleged unidentified snake bite, sustained systemic envenomation, could be neurotoxicity. So I would like to invite the panelists to have some discussion over this case.
Before that, can we ask all the panelists to open your mic and camera?
Okay, thank you. Very good. Can we see the case from the first page again, please?
All right.
Yeah. Okay. So just for your information, the patient applied minyak angin. In Malay word, minyak angin is hair oil. It's actually a local remedy. It's a local remedy. It's a kind of herbal what do you call massage oil, and they apply it over all kinds of things that they apply. Some pain or some muscle pain, they use this as well. But sometimes they put it over mosquito bites and so on. So in this case, they use this herbal remedy over the bitten side. Okay, we don't know how it's going to be affecting the bite or the envenomation, but unlikely it is actually causing all the systemic signs. Okay, so what do you think? Maybe Dr. York, you want to go first?
So we are in Malaysia, and that
Yeah,
means,
we are in Malaysia.
that means when you consider the snakes that can cause neurotoxicity in Malaysia, that would be common cobra, Najacauthia, that would be king cobra, and that would be Malayan crate or bandit crate. So these 4 snakes I would consider, beside other maybe very rare ones like Calliophis or others. Anyway, these four I think are mainly to be considered, and usually the crates would not cause pain. So that means he has a pain score of 5/10. That is quite strong already. And
moderate pain,
he
right?
has
Moderate, yeah.
Again?
It's a moderate pain, 5/10. Yeah.
Yeah, moderate pain, exactly. So usually the crate wouldn't cause pain, so and wouldn't cause swelling. So in this case, there's no swelling but pain. So it's a little bit tricky from my side to say what kind of snake that is. I think the reaction to give a polyvalent antivenom is a reasonable thing to do, and start with 5 vials. I would also do this and then observe the patient for maybe 2 hours. And if he deteriorate, I would give another 5 vials. And if not, if he's stable or improve, then I would observe the patient. So for the pain, I would go for the Cobra. For the not having swelling, I would be in favor for a crate. Yeah.
Okay.
So it's a little bit tricky from my side, I would say.
Yeah. Okay. Can you see the next page? What do you think, Miat? What's your take? Do you think kind of a similar presentation that you may have in Myanmar?
Yeah, for our country context, for the neurotoxic, we also, I think, same with your country context, straight cobra, king cobra, but the physical examination, it was bitten in the ankle joint. But for me, most of the neurotoxic snake bite in our country are cobra, but it should be present not in the around the ankle joint. It should be around the knee joint. It is weird for me. But there may be possible crate bite, but in our country, in hospital record data, it's nearly above 0 record in my country. I don't know about in your country. That is an interesting point for me because bites is in the around the ankle joint, and neurotoxic sign symptom is strange and weird for me, and that's the point. This after presenting this case. Yeah.
Okay, so basically, we can see that at the moment we can't determine the actual species, right? We are looking at things syndromically, right? As the presentation of the patient. So we can see here, he definitely have a gag absent, so definitely a neurotoxicity. Pupil is dilated, and there's the diplopia from the muscle of the paralysis of the muscle. And patient, but he's not in respiratory distress. So that's a bit strange, maybe. But he has, there's no mention whether he has ptosis or not. But from the management-wise, I agree that the choice is neuropolyvalent. So can we see the next slide? Yeah, so the distance of the bite is quite big. I think it's about 1.3 centimeter. So it could be, and as you can see, it's minimal, no dermonecrosis. If we are thinking like Dr. York saying, if it's cobra, there could be more severe pain, and actually they can also be a significant swelling from the cytotoxic effect. And also you can see that dermonecrosis, dermonecrotic changes. But the dermonecrotic changes, normally some people think it looks like ecchymosis or bruising, but it is not. There's a distinction between the two. And in this case, we don't see it there. So that's why we stick to the so-called unknown neurotoxic snake, and therefore they give the NPAV, neuropolyvalent antivenom from Thai Red Cross. Okay, so next. Oh, Dr. Amelia, are you following the case?
Yeah. I think it's
Okay, so what do you think? Your comment about the case, what do you think?
our setting, if it's in the Philippines, we may also consider cobra, like one,
Yeah.
Naja, Naja philippinensis or Naja samarensis. So, but
Okay.
then Malaysia, so Yorgo said
Yeah.
also Miat.
Yeah. That's
So,
Yes. Interesting that you mentioned Najas philippinensis and Najas samarensis. Are they occurring everywhere in the Philippines or different parts of Philippines?
Luzon and Visayas actually. And in the third island, Mindanao, there are also sightings of the Samarin more often.
Okay. So there is a
More,
different geographical places that separate between the two species.
yeah, because in Luzon, I mean, National Philippines is usually um, seen or observed to be present in the first island. So remember, it's Luzon, Visayas, and Mindanao. So
Okay.
Luzon, mostly Philippinensis is the one that's seen, and then Visayas and Mindanao, Samarensis. These two
Okay.
islands.
All right. So, York, what about in Vietnam or Laos? You have several species of cobra, right? And almost all of them are spitting cobra, except for maybe monocle cobra.
Well, there's monocled cobra in Laos, and there's Naja siamensis in Laos, and probably also in the north, Naja atra, the Chinese cobra. So we had one case in the very north of Laos. There was a spitting accident, and I guess that was close to the Vietnamese border, and I think that was a Naja atra, Naja Chinese cobra. And in Vietnam, it's the same. You have Naja siamensis in the south. You have Naja cauthia in the south and center, and in the north, there's also a mix of Naja atra and Naja cauthia. Maybe the Naja cauthia is introduced into the north, while because they are breeding the Naja cauthia near Hanoi, and maybe some of these species escaped into the nature, and now they have a mix there. But you have to consider also Naja cauthia. And for the signs, for adults, the Naja siamensis, actually in the south of Laos, I never really saw an adult person with severe neurotoxic symptoms. For children, yes, small children, yes, they have also neurotoxic symptoms with Naja siamensis, but mainly Naja cauthia is causing neurotoxic symptoms and respiratory failure in Laos. That is my observation. And Naja siamensis, the spitting species, is mainly causing severe local cytotoxicity.
Yeah, because in Malaysia, we have two species, as you mentioned, Naja sumatrana and Naja cauthia. It's interesting to note in this case, it's occurring in south of Peninsular Malaysia, which is in Johor, the state of Johor. So the indigenous cobra is Naja sumatrana. The Naja cauthia is in the northern state of Peninsular Malaysia only. But we do have some cases which was found in Malacca, the next state in the south of Peninsular Malaysia, and it was confirmed to be Naja cauthia. So as you said, probably this species, the monocle cobra, has been introduced into the local population in the south. And we are also seeing this Naja cauthia in some cities in Sarawak and Sabah, and these are major cities where it's quite close to the port. So most likely either is being introduced. They are not indigenous. Naja cauthia is not indigenous to Sabah and Sarawak, Borneo. But we had cases and mainly in the big cities, and we think that this is also introduced either through trade, meaning that they follow the container and then open the container and they go around and found new home, or people actually keeping this monocle cobra as pet, either illegally or breeding them, and they don't like it anymore and they just release it to the community. So this is not really a good practice. Is introducing what do you call exotic species to the local population, and they will have some tough time to compete. Okay, so yeah, so can we see the next slide?
Dr. Al, sorry, just want to add.
Yeah, go ahead.
I forgot to mention the king cobra.
Yes.
The star among these
Yeah.
king. Call it
Yes.
one. Actually, it was the most recent incident was found in. I mean, was had occurred in Mindanao in Davao Oriental, where they killed the cobra actually, and this drunken man um, um, put the mouth of the king cobra on
Oh,
himself,
okay.
and you can check it out in YouTube. It's there, and so like right after about 15 to 30 minutes, he's dead.
Oh, yeah. Yeah. Do you have this type of practice in Myanmar? Do you have people, what do you call, trying to gain immunity by getting the snake to bite them?
I heard it about from the zoology, Yangon zoology
Okay.
team, but it's not practiced currently. I think it's around 1980 or 85. They usually used to do that, but we don't know that it is the real practice or just only gossip. Or, but we heard that they are doing practice as an immunization.
So,
Yeah,
so we
zookeeper.
had
Yeah.
we had a case as well, an elderly man, and he play around with snake, and he have king cobra, and he also try to achieve so-called immunity by asking, or not asking, by making the snake bite him, and he ended up in our hospital. And the thing about king cobra is very interesting. It's not just about the venom, but also um, the way that it bites. So the king cobra bites and hold, and therefore the longer it bites, the more venom will go into the body, and therefore more severe the symptoms. Okay.
Yeah.
Yeah.
I think what happened, Dr. Kalk, because this guy was not injecting himself to
Oh.
for the immunity. It's just to show off, to be honest.
Oh. Okay.
And he just boasted and then, see, look at me, blah blah blah, and then put it there on his own hand. Thereafter, the neurologic signs and symptoms manifested, and then a few days dead. So it's crazy.
Okay. Yeah. So, York, maybe you want to comment on the management here. What do you think?
Well, I'm ask myself why hydrocortisone is given to this patient.
Yes.
That is my question. And naloxone.
And Piriton. Yeah. I don't think there's any. Is there any incident or any report of allergic reaction for this patient? Moderators?
No, Prof.
Yeah, so we are a bit taken aback here. We note that the patient was given hydrocortisone, given IV Piriton, assuming that they are meant for treating allergic reaction. And the Maxalon is prophylaxis for the opiates is given, which is IV Tramadol. So it's kind of automatic. People give sometimes for snake bites unnecessarily. So we've been trying to correct this practice, but it seems to be very difficult. Patient was given, automatically without being consulted to the consultants or to the doctors. So especially, let's say they come to the rural clinic, which are managed by mainly the medical assistants. So they don't have any senior doctors to consult, and they just give prophylactically. It's kind of like, you know, any animal by sensing, they will get this type of medication. So it's quite difficult to re-educate the medical faculty in that sense. Do you give this also you see this also in Laos or Vietnam or Myanmar? Giving
Yes.
so-called prophylaxis against allergic reaction or snake bite?
Yeah, it's usually
I
given.
think the
Okay.
sorry, sorry, Josh.
Yeah, go ahead. Go ahead.
Yeah, Mexalone and anti-TT. They are also we in our country also use these things. I don't think about tramadol.
Okay. You said ATT, right? Tetanus toxoid?
Yeah, yes, yes.
Yeah.
Anti-tetanus
Okay.
toxoid. Yeah.
That's interesting. What do you think, your
What is this?
anti-tetanus toxoid,
Anti-tetanus
ATT?
toxoid. Yes.
Yes, usually, I mean, that is indicated, I think, to give a toxoid, but you can, it's maybe not a medication in the acute situation, but I think it's always indicated in patients who have a unknown vaccination status on tetanus. Yeah.
Yeah. So that's always follow the standard guideline from the WHO for tetanus. You need to know what is the tetanus vaccination status of the patient. So if, let's say, the patient had the last injection or booster shot more than 5 years ago, then you can actually give the patient the next shot for animal bites and stings. But if it is less than, let's say yesterday he fell down and motorbike and he came to emergency department, he got a ATT tetanus shot booster. Obviously, today they come from snake bite, you don't need to give anymore. So that's the problem. In Malaysia, sometimes they forgot to ask this. They just automatically give this ATT for all patients with animal bite and sting, or for all patients with injuries, skin laceration, and so on, without asking the status of their tetanus vaccination. So it's a kind of a waste of resources, actually. So this is another thing that we have to educate our medical fraternity, our medical colleagues, not to give, I mean, not to simply just give without asking the status prior. Okay. All right. So next, how is the patient progress? Is it okay?
For this patient, we don't have the patient's progress. This is all we
Okay.
have. Yeah.
Okay. All right. So I think that case can be managed. As you can see, this case is most likely is correctly diagnosed, unidentified snake bite with neurotoxicity, most likely from an elapid bite. So we don't know whether it's a great cobra and so on. But from the sign symptoms, I would go more towards a great bite because of the physical sign and symptoms is mild to moderate as compared to if I were to expect from a cobra bite. Unlikely a king cobra, unless it is a baby king cobra. But then the king cobra venom also can cause quite similar symptom to the cobra bites. So coral snake is very unlikely because the size of the bite is quite big. The coral snakes in Malaysia we have several, but we have very little that shows signs of neurotoxicity that we have encountered so far. Okay. All right. I think we leave it at that. Can we move on to the next question? Or do we have any questions? We have a few questions there, I think.
Yeah,
Ask
we
the
have.
questions.
All right. So for the first question, someone asked about what is the first thing someone needs to do if they are bitten by a snake, and what is the first aid someone can do for themselves?
Maybe Dr. Mian, first aid.
Do it right.
Yeah, in the your case study, it's mentioned that squeezing of venom from
Yes.
the bite side is a very dangerous sign.
Why is it dangerous? Why is it why shouldn't we squeeze for first aid?
Yeah, it's favor for the systemic envenoming.
So it can
Yeah.
spread. It can spread faster, right? If
Yeah,
we squeeze
yes.
and massage. Yeah.
Yes.
They think that when we squeeze, the blood come out and the venom come out, but it's not true. The venom is in the lymphatic system. So you squeeze and massage, it will actually promote it to go more proximally and go into systemic. That includes also movement, right? The more we move, the
Right.
faster the spread.
Do it right.
Yeah. Yeah. So the M, what do you want to say?
Do it right. Right?
Do it right. Yes. Okay.
Lies,
So
go to the hospital and tell the doctor. Do it right.
yes. Yes. And they just need to immobilize. I think that's the first aid that we encourage people to do, reduce movement and call for help and go to the emergency department as soon as possible. Not so much of a local intervention. I remember in the past in Indonesia when we first engaged, there were a lot of cross incision. They do a cross incision over the remember just now we saw the two puncture wound. So each puncture wound had a cross incision. And then they will encourage blood. Some of them will suck. Some of them use these devices or sucking devices, to remove the blood. But we had a few of those cases and they died actually. Yeah. Is it still widely used in Vietnam, Laos? Yeah.
Yes, you see it sometimes. These cross-shaped incisions, you see it not really often, I have to say, but you see it. It's still sometimes used also in hospital, actually. Sometimes the people think you have to make an incision to get the venom out of the wound, but it's not working.
Yeah, so in Malaysia, we don't.
I've seen
dangerous, right?
2-3 cases who developed coagulation disorder, and then you have a terrible bleeding from these incisions. So that is just
so it can introduce infection as well, right? That's another thing.
It's infection. Also, you may damage nerves or blood vessels or tendons or whatever with these incisions. It's just
so in Malaysia, we don't see that often people cutting, but we do see it sometimes. But most of the time, majority of them will tie. Will do a tourniquet and tie as in sometimes several places after the bite, and thinking it will stop the venom, but it doesn't actually. It causes more problem with swelling and also masking the problems. So we try to discourage that tourniquet application. So anyway, any other questions?
Just one more. What's the significance of the distance puncture wound in the snake bite?
Okay, so the puncture wound, the distance between the two puncture wound, what's the significance? Anybody wants to answer? Why do we measure the distance between the puncture wound?
Yeah, you may get an idea about the size of the snake, but so if you have a distance of maybe 2.5 centimeters, you would have a quite huge snake, probably that bit the patients. But I always say be careful with the puncture wounds and with any interpretation from puncture wounds, whether it's non-venomous or venomous. It gives you an idea, and also the distance gives you an idea about the size of the snake, but it's just an idea.
Yeah, so that's a very interesting question as well, because the distance between the two can also doesn't say whether it's an adult snake or baby snake, when they're small, but it doesn't really reflect into the actual snake. And mind you, there are some non-venomous snake bite which appear to be two puncture wounds. We see this quite often in Malaysia with our Homalopsis bocata, our water snake, and what do you call this, plumber's water snake. So their bite, strangely enough, have 2 puncture wounds, but they are non-venomous snake. So this can give a misinterpretation that you think that this is a venomous snake. So if you don't have the species, then difficult to judge, and we always go for the syndromic approach. Okay, any other question, or can we move on to the second case?
We can.
Can
We
I
will move
ask,
on to
like for example, because we are talking about the distance of the bite,
Yes.
is it like is there any study or research done on like the the snake species, the distance between the fangs, or would it be like sensible to say that it could also be a way to determine the species that caused the bite or something?
No. As Dr. York said, that doesn't really make any sense to do,
Really,
yeah.
like, and is it safe to say that we cannot tell the distance of the bites?
We cannot associate the distance of the bite
Okay,
marks to the
so
species of the snake.
there is no association whatsoever.
So difficult to make. What
Okay.
if you only have 1 puncture wound? How do you measure the distance?
One, one, one,
One
one.
is broken, is it? Or sometimes we have snakes which has more than 1 fang on one side of the mouth. So you
Okay.
might have 6 puncture wounds, but there are 3 on each side, and this we see in pit viper bites.
All right.
Okay,
So
yeah.
it's
So
there's
it's
no association.
no, don't make that association. Don't fall into that trap.
All
Yeah.
right.
Okay. So okay, shall we go for another question or next case?
Okay, thank you, Doctor, for the inputs. We will move on to the next case. So it's a case of unidentified cause of injury. So for introduction, this is a 30-year-old Malay gentleman with no non-medical illness and no drug or any food allergies. He working as a cow shepherd. He took sleeping pill for 2 days given by friends. They call it ubat apo due to the family problem, and the last taken was at 3 a.m. on the incident days. He came to the emergency department due to unknown animal bite over the right shoulder around 12:45 p.m. incident day. So initially, patient took care of the cow in the palm oil behind his house at Jaya Garden, Kuantan. Then he found chicken in the farm and wanted to catch it. However, chi- the chicken hide in the drain of 3 feet deep with water up to his ankle. Sometimes, when he go down to the drain, he felt something bitten him over the right shoulder around 4 5 seconds, but unable to identify what animal was it. He claimed that he only saw a glimpse of black cylindrical 2 to 3 feet long animal with hissing sound. Then went away as soon as he turned his head around. After that, he felt a sudden pain over his right shoulder with a pain score of 5/10, and it was bleeding. It was associated with central chest pain and dizziness. He applied tourniquet over his right shoulder using his shirt to arrest the bleeding. It was removed in the emergency department. He had around 1 hour rest at farm when the dizziness subsides. He called his friend to bring him to the hospital. They arrived at the hospital 2:30 p.m. on the incident day. However, there's no shortness of breath, no vomiting, no hoarseness of voice, no loose stool, and no blurring vision. On physical examination, he is alert, not tachypneic, no pitosis, no leak lag. The BP is normotensive, the heart rate is normal, the temperature is febrile, and the SpO2 is 99% under room air. All the examination are normal. On the local examination, on his right shoulder, it's not on the bitten area, it's not swollen. However, there's 2 fang marks 2 centimeter apart with minimal bleeding from one of the injury, and there's no dermonecrosis. On the investigation, all were normal except for the liver function test, which is the AST and ALT is elevated. For this impression, is alleged unknown bite over the right shoulder. However, is to rule out acute coronary syndrome secondary to the first injury. For the management, they do IM ATT 0.5 mg stat and IV tramadol 5 mg, IV maxolon 10 mg, and bleeding was stopped with adrenaline pack, and wound was clean. Post analgesia, the pain score reduced to 2/10, and the chest pain resolved.
Okay, can we stop here for a second? Maybe we can get some input from our panelists before we move on. Quite interesting. Can we show the injury?
All right.
Yeah. So any input, Dr. York, Dr. Miat, and Dr. Emily? What do you think could cause this? So this one, the distance, as you can see, is quite big, right? How many centimeter? 2 centimeter. Yeah, yeah. What do you think?
Well, for
From the
the local signs there, with a little bit of black discoloration, and the place where the bite took place, the drainage, I would guess it could be a cobra, because the cobras like to be in the water, and there may be bit him there in the drainage where he didn't see anything, and the bite would also fit.
Yeah, I would say it's a very big cobra. Could be a king cobra. 2 centimeter.
2 centimeters.
Miat, what do you think?
Yeah, it's possible because he was going down to the water and can be bitten by the cobra. Maybe cobra or probably king cobra, but it's 2 centimeter apart from each other.
Yeah. Emily, do you think it's a snake bite?
With the signs and symptoms that he presented, you may think otherwise. It could be some other animal, but with this picture, as was mentioned by Dr. Miat and Yorg, I think I still would go with cobra.
Okay. So just to bear in mind, this is someone with a history of drug abuse or taken some drugs. So this is the history that he gave us. Okay. Anyway, shall we move on?
Okay.
So after the wound was clean, this is how the wound looks like. It's like a triangular shape.
So maybe Dr. Yerk, can you identify this cause of a snake? Which snake?
That doesn't look any more like a snake bite. Actually, it's like a antibody shape, no?
Yeah, antibody. Mercedes-Benz sign.
Mercedes-Benz, yeah.
So,
maybe an injury
very interesting. So you can see just now you mentioned there's a kind of a discoloration, right? You think that initially probably it was dermonecrosis and the puncture wound. Yeah. But this is, what do you think, Miat and Emily? Have you seen this type of pattern for snake bite? Now it's very interesting because just now you said distance, right? And you mentioned, is there anything in the pattern, if the puncture can be identified to a snake species? So we have this now.
As you can see, that like the other bite is like bigger, so much bigger than the other one. They usually come, when we observe snake.
So maybe one side of the fang is bigger than the other.
Or
I think it's not possible.
Yeah,
it should be symmetry.
It's quite rugged. It's like it's not the usual smooth, smooth like that. I don't know.
Thank you. That's the point. Most of us from those who already seen snake bite, many cases, this pattern of puncture doesn't really go with the typical snake fang puncture, right? Most of the time, as you said, is smooth. Because if you see the fang also quite smooth, so you feel like it's like a puncture of a syringe, you know,
Like
smooth.
a
Yeah.
ragged.
This one is very ragged, right? It's not just ragged, it's a very interesting pattern, right? So maybe a Mercedes species. Yeah. So
No
it's a
manipulation.
kind of a, yes.
No
So what
manipulation.
comes to your mind? What comes to your mind now?
No
All the
manip
blood tests are normal. The swelling is not really progressive. You can see very minimal swelling there. No more bleeding.
no manipulation done initially at the site, because like the incident happened to 40, they got to the
Yeah.
ED at 30.
No manipulation. Meaning that we're thinking of like cross incision or something like that, right? Apparently no self manipulation.
Okay.
Yeah, so this is the question that we pose to the doctors who are managing the case. So this strikes to me as something which is unusual. So can we move on? Let's see what's information that we can get.
For the progress, after the injury did not look like an animal bite, they asked a forensic expert to see, and it looks like a scraper stab or tri-point screwdriver. And further history with the patient, is there anywhere he go before comes to the emergency department, or did he try to cut through the wound or suck any fluid out, but the patient denies it? Further history from the relative, the patient had multiple history of positive urine drug tests. However, the patient denies it. Otherwise, the bleed after a while, the bleeding stopped. No shortness of breath, no chest pain, only complaint of joint pain at the knee and shoulder. And the hemoglobin is normal. The platelet is normal, and the INR is 1.1. The final diagnosis is unidentified cause of injury. This is what we mean by the tri-point screwdriver or the scraper stab.
Yeah.
Scraper, yeah.
Mercedes Benz.
Okay, so what do you think happened?
Maybe he got injured or he tried to harm himself, but he doesn't remember it. So
Yeah. Okay, so
Correct.
just to give you a bit of a context, yeah, go ahead.
Yeah, maybe he got injured in the drainage, just from a foreign body or from the drainage
Just
inside.
You think that there are two scrapers sticking out in the drain and he just bumped into it, right?
Yeah, or whatever there.
So that's a very strange story.
Go
So
for
this is
the
actually
syndromic.
syndromic is fine, it's clear, right? There's nothing there.
yeah.
It's
Yeah,
nothing there, so you could at least rule out envenomation of a viper or a neurotoxic snake in Malaysia.
Yeah.
So that then
But
you go ahead.
he's adamant that it is a snake bite. We confronted him and said this is not a snake bite. We said no, doctor, this is a snake bite. So just to give you a context of when this happened. This happened actually during the second MCO of COVID-19. So during COVID-19, a lot of people had to stay home, no jobs, but the issue is that in Malaysia, for those who are bitten by wild animals, snakes included, they can actually claim compensation from the government. So yeah, quite a lot. Yeah, so quite a lot. So one of the thing that they have to do is to make to get the doctor's report saying that this is a snake bite and it's accidental, and therefore they can claim the money. So and as you can see from the background, he's also a kind of a drug abuser. So we feel that he's actually compelled to either do it himself or get a friend to do it for him, is to puncture his shoulder twice. Okay, so now that's where you can see, if you remember from our training in emergency, if somebody is trying to commit suicide by slashing, right? So we have slash wound. The initial slash is very light, typically. Then subsequently, it become deeper and deeper, right? First is trial, and then get more courage, and then deeper. So we see just now the two different sizes. Most likely, the first one is just a trial, and then the second one is more determined. So one size is deeper than the other. And you can see the ecchymosis. The one that we saw just now is ecchymosis. So that's because of the pressure from the instrumentation, from the puncture wounds. Okay, so that's not from dermonecrosis. That's for ecchymosis from the mechanical injury. So this was our forensic report that we made for this case. So I consulted a friend as a forensic professor, and we discussed about the case, and we come up with that conclusion. So this is a very interesting case that we had. We use this as a case study for forensic students. So it's very nice to see this. So we always sort of like, oh, this must be snake bite. To puncture wound is always snake bite, but it turned out to be the other way around. Yeah, it's not. So people, if the doctors treating the patient not aware of the possibilities, they will just sign and okay, this is a snake bite injury. Okay, we'll make the report, and they can get the claim the money. Yeah. So anyway, the patient.
How much do they get, Dr. Carl?
Not enough actually, but it's quite a lot. It's a few thousand. I think it's about 20,000. I think about 20,000 ringgit.
Oh, that's
Yeah.
quite a lot.
So depending on the severity and so on, and how they manage in the hospital. Okay. So yeah. So this tool is mainly used for carving work. If you work with wood, the wood carving, you have this type of what you call instruments. Okay, so very interesting, right? So any questions? Can we answer any question? Is there any questions?
I don't think so. I think we can proceed to the next case.
Okay, I think there's a question
That's
a lot of question in the Q&A box. You check the Q&A box?
Because some of it was like from the previous case.
It's okay. Can you just ask a few?
Okay, I can ask a few. So here is there any specific lab tests or imaging that we can order to evaluate the extent of the envenomation?
Yep. Is there any specific lab tests?
For neurotoxic, no, we cannot easily measure the concentration of venom in the blood. That is too difficult, and there's usually no acute measurement possible. For neurotoxic snakes, it's clinical signs of neurotoxicity, and for hematotoxicity, this is the correlation test. Usually INR and proton beam time. So if it's unmeasurable, you can say, yes, that is severe envenoming, definitely.
What about pit viper bites? Is there any pit viper bites? Is there any specific test that we do?
Just platelet count and proton beam time.
Yeah. So that's the answer is there's no real specific for particular species, but the test is part of the syndromic monitoring of the patient. So it's not just a clinical sign and symptom, but also we couple with lab tests. So for pit viper bite, we don't know the species, and most likely somebody can develop coagulopathy. Then that could be a sign for us to give antivenom. So similarly, for cobra, you have a lot of cytotoxicity, or even sea snake, myoglobinuria causing rhabdomyolysis. So we check for myoglobin and also CK level. So these are not just standalone tests to suggest one particular snake envenoming, but it must be coupled with always with the clinical sign and symptoms as well. So that's very important to note. Yeah. Okay. Any other question?
We have another question. What makes pressure bandage with immobilization technique different with tourniquet technique? Doesn't both method are applying pressure to the affected area?
So,
For the first
sorry.
aid. What makes
Maybe
pressure bandage with immobilization technique different with a tourniquet technique? Does not both method are applying pressure to the affected area for the first aid?
would you like to answer that? Anybody?
Well,
Yeah.
the idea of the immobilization bandage is that you apply pressure to the lymphatic vessels, that you compress a lymphatic vessel and you slow down the resorption through the lymphatic vessel. That is the idea of the pressure immobilization bandage. Whether that is really working and achievable, that is maybe the question. So I prefer to tell the patient go as soon as possible to the hospital if possible. And usually you don't have the bandage at your hand, and also to apply the bandage, it's you need to be quite skillful to do this properly.
Some say you must actually undergo some training before you can actually do it. So
Yes.
it's not just simply apply. You have to be some training, and it's good, and then you apply. But the difference is that the tourniquet only tie at one area, small area, whereas the pressure bandaging immobilization is like the whole limb that is affected. So it's more pressure bandaging is impeding your lymphatic system, the whole lymphatic system draining the limb, but is more regulated. But the tourniquet is only one side, then that it can actually also when you apply tourniquet, it's very tight. So most of the time, people will have problem with circulation to the limb, and that triggers also swelling of the limb and can mask the underlying possible envenoming. Okay. Any other question?
I think that's for now. I think we're moving to the next case. Thank you, doctor, for the inputs.
Okay, so going to the third case, which is a jellyfish sting. So from here, we can see there's actually a statement that was issued regarding 5 cases of the venomous sting from the Portuguese man o' war reported from Pantai Butik, Keluang, Terengganu. And from here, the statement said, advise the public not to swim or do any recreational activities at this beach and any nearby beaches to it. However, if you suspect to have been stung by this venomous jellyfish, immediately get treatment at the healthcare facility. So this was in 23rd to the 24th of February. And subsequently, in 26 February, there was another public notice where the Department of Fisheries Malaysia stated that the appearance of the Portuguese man-o'-war jellyfish at the coast of Bachok District, Kelantan, which is most likely due to the monsoon season. And previously, this jellyfish species was mostly detected in Thailand, Pahang, Terengganu, and Sabah. And if this jellyfish is found other than the stated area, which is Kelantan, the public should contact the District Fisheries Office regarding this. So from there, on the 4th of March, from one of the newspapers, it had stated that the State Health Department received 6 cases of stings from the venomous jellyfish, which is, the name is actually Physalia physalis species, that involved children of the age of 1 to 11 years old. And this jellyfish was detected in Bachok, Kelantan, where 2 cases were from the Melawi beach and 4 cases from the Baru beach. And these victims experienced symptoms of pain, swelling, and itching at the site of the sting. There was no antivenom for the venom caused by the sting of this jellyfish species, and treatment was given only to relieve the symptoms. I think that's all regarding the jellyfish. It's more like a statement.
So,
Yeah.
maybe this is in the backyard of the Emily Santa Maria, our jellyfish expert. Em, would you like to comment about this? Do you have a similar condition at the moment in the Philippines? Because it seems to be coming from there.
Oh, really?
No, I don't know. I
um,
don't know. I'm just
so far, Dr. Kyle, we haven't had any cases of this because this is the blue
blue bottle.
bottle, yeah, blue bottle.
Yes.
So more often than not, they are seen on the beach. That's usually the case when these blue bottle jellyfish are seen. So relatively, we don't really have that much cases of jellyfish, blue bottle jellyfish sting.
Okay.
And if I remember it right, it was almost 2-3 years ago that we had this incident that they were washed off on the beach. So we don't really have that much problem with regards to jellyfish stings with blue bottle jellyfish. So and but I think uh it is also relevant to have these kinds of advisories because some people would see it as something beautiful, and we already we have been teaching, or we have been telling people that when it's beautiful stuff, don't
Mm.
don't touch it or don't hold it, because more often than not, these are the marine animals that are usually dangerous, and these are the ones that causes the serious stings, and fatal stings even. So I think this advisory is very relevant, especially when they give out updates, like when you try to give an advisory. I think it's relevant to have a succeeding update on that particular advisory that was initially released, so that at least people will also be able to understand the whole process of why this advisory gets to be released in terms of educating people, actually.
Okay. So yeah, we see this sometimes of the year, but it's not all the time, and it seems to be following the Gulf Stream on the Thai
What,
Gulf Stream
what,
coming down. Yeah, from the Philippines. I mean through South China Sea, and then going to the Thai Gulf, and then going down to the east coast of Peninsular Malaysia. So the interesting thing about this species is that this is not a true jellyfish. It's a commensal of various organisms formed into one. So the bottle there you can see is one organism. The tentacles there you see is another organism. So they live together and form one big community. So this different different to the true jellyfish, which can actually swim and directing where they want to go according to the stimulus. But the blue bottle is mainly at the mercy of the elements in the sea, either by the wind. That's how they use the bottle. The wind will help them float and push them like the sailing boat on the surface. And if they want to not to float, they will just reduce the air inside the bottle and they will submerge. So that's all they can do. They cannot really swim, actively swimming to the direction. Different to the box jellyfish. They are very active swimmer and they are hunter. So they can detect where the fish is, they can chase after the fish and so on. Okay, and they can avoid obstacles that we have seen. So we had a few cases of sting. And the sting, as you can see there, the report says is mainly symptomatic relief. We just give painkiller, observe for a few hours, make sure there's no cardiac issues, and then we can just discharge. And so far, the skin marking from this species also is not as severe as the box jellyfish that we see. I think in Myanmar, you have this species as well, isn't it? Have you heard about it, Myat? I'm
Yeah,
not going to
Professor.
ask about Laos because Laos doesn't have a sea. So
And luck.
Prof. Carl, we have sea, but
Not yet, not yet.
no, yeah,
I don't have
maybe on the
experience of this.
table in the restaurant, people eating this. I don't know. Yeah. So,
I'm
but
not
Myanmar has
We
this
have sea,
species.
but we have sea, but we don't have this kind of jellyfish thing and not reported data.
Oh,
Maybe under
yeah.
reporting.
Okay, maybe.
Yeah.
So we have this also in Indonesia. Indonesia also has this species. Dr. Maha has a report about these cases quite a lot. But we so far in Malaysia, we've seen this somewhere in the east coast of Peninsular Malaysia, not so much on the west coast of Peninsular Malaysia and the Straits of Malacca. Maybe it's protected from with Sumatra. We have heard about some of the reports from the coast of India, maybe Madagascar, and what do you call India and the surrounding area and the sea there. Okay, but we hardly see any in our west coast of Peninsular Malaysia. Yeah, so that's quite interesting. So treatment is just syndromic approach. Yeah. Okay. Any questions? Any other questions that we can entertain?
Apparently, some of the
There's
students are
usual
not able
fatality
to
for
it in the WhatsApp.
Fatality. We have not report any. We have not encountered any fatality from this
Not
species, but
blue bug.
not from blue bottle. But I think in
Only
Australia, I think in Australia, right?
only box jellyfish.
Yeah, I think Australia had very little number of report of death from blue bottle in Australia, but not from our country that we know of. Yeah. So any questions?
So the question is there a golden hour to get treatment after a jellyfish sting?
Yeah, box. If it's a box jellyfish thing, oh goodness, they have to go to the hospital, be brought to the hospital. Of course, our first aid treatment would be the ever famous acetic acid, vinegar. Just like what the Dr. Carl said, is supposed to be included in what to bring to the beach, right, Dr. Carl?
Yes.
And then and so the question after that, since you said that, it's does applying vinegar and baking soda help with the jellyfish sting?
Vinegar only, not baking soda.
So only vinegar, not together.
Yeah.
Right.
Yeah, unless you're making scones. Yeah, you can use baking soda.
I know you would say that.
Uh,
And the key reason is to bring the patient to the hospital because you will be able to give more like supportive treatment with the case.
I see. So just now, doctor said that you give acetic acid. So is it, other than that, what can be done initially if there's a jellyfish sting incident prior to the ED transfer?
Well, get the patient out of the water safely, and then you can like put the vinegar on the area affected, and then with something with maybe uh, what's that we say, Dr. Carl, to take out
The tentacles.
use a card or
Scrape. You scrape it off.
with something, but not, don't touch it.
Oh,
Don't the tentacle. So use something to remove the tentacles so that it will not be able to release the venom anymore. So that's one of the reason why you have to remove tentacles. Use something, maybe a card, because when you are in the beach, of course, you don't have the tweezers. Do you bring tweezers in the to the beach? I don't think so. Because it's ideally it's a tweezers, because that's why when we go out to educate especially the healthcare workers in the coastal areas, we already advise them to have a kit that's like included in their first aid kit. So these are the things that we can prepare for, because uh, especially if your area is prone to or have record high records of um, box jellyfish stings.
I see. All right. So last question. Is there any permanent damage or side effect caused by the jellyfish sting, since there's no antivenom for it?
I didn't get that.
Is For the last question, is there any permanent damage or side effect caused by the jellyfish sting, since there's no antivenom for it?
Damage? I mean,
Like permanent damage, like, or side effects,
Complication.
like complications towards this sting.
you die.
You
That's the saddest part of box
Uh-huh.
jellyfish,
Mm-hmm.
right, Dr. Cal? So that's the one reason why it's really important to have an antivenom. And your government is very fortunate to have that. We
Mm.
don't have
Yeah.
it in the Philippines now.
Yeah, so our antivenom in Malaysia for box jellyfish is also very limited. Uh, it's not for every places in Malaysia. Especially in the coastal area. So the one that is stocked, the box jellyfish antivenom is only in the state of Sabah at the moment. Because we had a lot of cases of box jellyfish sting causing even death been recorded in Sabah. This is very close to the Philippines as well. So, and we have used this box jellyfish antivenom several times, with apparently, appears to be good results, but there's no real good study to show that it is actually working or not. Okay, but since we have it, we used it according to the indications and also the guidelines when to use it. So it's not meant for everybody as well, similar to the antivenom for snakes. Okay, but so far the box jellyfish is mainly in the state of Borneo, but in the Peninsula Malaysia, we have seen already cases of box jellyfish sting and causing death in Pangkor, in Langkawi. Yeah, and we have very strange group of jellyfish injuries also in the coast of Penang. So, but so far no antivenom for box jellyfish is stocked in the west coast of Peninsula Malaysia.
Yeah.
Okay.
And I just like to add, those who survived, they have very ugly looking stains. Oh, stains. No, not stains, but marks. The the typical marks, the whip-like marks. They stay.
Yeah.
They stay on. That's why it's really difficult to remove that
Yeah.
ugly scar.
Yeah. The scar can be actually turned into keloids, so they can actually become very prominent. But most of the time that we saw the scars and so on quite superficial. So when the skin changes, then the scar will go. But maybe some marking is still depending on the depth of the injury from the scar. Yeah.
Yeah. So it's very important to avoid prevention. Prevention, wearing your clothes, your
Yeah.
um rash guards when you go swimming, and of course don't swim in the sea that's identified to have jellyfish, those things. And then make sure that you have a warning. And also one of the things, especially like in those areas with high jellyfish sightings, like in Australia, in Thailand, even here in the Philippines. They use, they make stations where acetic acid is already available. And there's this funny thing about it, because we want to have it colored so that they will not be used for um, like vinegar for eating to just stay there. So color it blue, put some food color, but I'm not so sure. Um, th- um, does it have any effect, Dr. Kal, if you put some food colorings on the
Uh,
I'm not so sure, because that's the joke that we have, because they might, we call it, I'm not sure about in Malaysia, if you use vinegar like when you eat something like cracklings
yes,
and
yes.
chip.
Yeah, so vinegar has been used for jellyfish sting first aid for so long. But again, new studies shows that it can actually make the thing worse, depending on the species of jellyfish. So we still advocate it in Malaysia partly, but now there's some study also shows that we can apply lignocaine spray or lignocaine. But who brings lignocaine to the beach, right? You can you bring your vinegar for your food for picnic, so that's available, right? Yeah. So yeah. Anyway, but if you are a paramedic and so on, and you are stationed at the beach as a what do you call a first aider, then maybe a lignocaine spray will be helpful. Besides reducing the sting from discharging, it can also reduce some pain. Whereas vinegar, it doesn't have any analgesic effect. It actually can cause more pain, right? Because your skin is exposed. Anyway, yeah. So these are still in the controversial side. More studies perhaps is needed. Most of the advice are on empirical kind of what you call not really fully scientific. We see a lot of uh, contradictions in the studies that's done. Some suggest okay, some suggest not okay. So it's very difficult to make that distinction. But the most important thing, as you said just now, if anybody sting, first you need to know how to do CPR. They can collapse in front of you within minutes. So please do CPR. Don't need to pour vinegar. There's no point anymore. And also get to the hospital as soon as possible. Yeah.
And
Okay.
that's why, Dr. Kal, just to mention, in all our trainings for snake bite and marine envenomation, we incorporate BLS, basic life support.
Yeah. So medical students is imperative that you need to know how to do CPR, basically. Yeah, at least, especially during the medical posting, emergency posting. Okay. All right. So do we have time for another case or
I think we can have another one.
okay?
Okay, so thank you for the input just now. So for the fourth case is an unidentified snake bite with local envenomation. So for the history, it's a 35-year-old Indonesian man with no known medical illness presented to the ED with complaint of snake bite over the left ankle. He was bitten on the 26th of January this year at 8 p.m. at the back of his house near palm oil plantation site. He did not notice the snake and accidentally stepped on it. The snake escaped after biting him. No photos were captured. Patient recalled that it was all black, no stripes, 70 to 80 cm long and 4 cm in diameter, possibly a Naja species. Pain score when he got bit was 5, with minimal bleeding at the wound. Subsequently, he returned home and applied self-made tourniquet below his left knee and was brought to the ED at 9:52 p.m. So upon arrival to the ED at Hospital Bakar Sultanah Fatimah, he vomited once, no neurotoxic symptoms, angina, abdominal pain, and diarrhea. So for physical examination, patient is alert, comfortable, and GCS was 15. Vital sign shows blood pressure was normal, pulse rate was normal, temperature A febrile, and oxygen saturation was 98% under room air. For his examination for his cardio, respiratory, and abdominal were all normal. However, for his lower limb examination, there was 2 fang marks seen at the left middle aspect of the ankle, and the ankle appeared swollen. No bleeding or discharge seen at the wound site. Left calf appeared swollen. Distal pulse artery was palpable, and the capillary refill time was less than 2 seconds, and there was no dermonecrosis. So this is a picture of the fang bites. And
puncture wound.
the puncture wounds. Yeah. And then for the investigation, it was actually all normal. So for the patient progress and management, the pain score improved to 2 after a few hours. However, the swelling over the left lower limb worsened and progressed proximately, and there was a slight dermonecrosis present. So he was then given analgesic IV tramadol, which is 50 mg, TDS, then paracetamol, and also diclofenac. Patient was then referred to the orthopedic team to rule out the compartment syndrome, and an ultrasound from the post protocol was done and noted subcutaneous edema. Serum creatinine kinase increased in trend and was monitored 6 hourly, and the rate of proximal progression of swelling 4 hourly. And blood culture and sensitivity was done on the 27th, which showed no growth. From there, the patient was given anti-venom Nahacautia first dose, which is 5 vials, administered on the 28th, and there was no signs of hypersensitivity. And the pain score post-anti-venom improved to 1, and dermonecrotic area has reduced in size. Then we had done another ultrasound, and it showed improvement in the diastolic flow at the polyp tail and posterior tibial artery. The serial RPP and CK trends was improved as well. And broad spectrum antibiotics, which was ampicillin /salbactam, initiated on the 29th in anticipation of the wound debridement. So this patient was actually discharged on the 30th with the orthopedic follow-up to review for the need of the wound debridement. But then he decided to seek further treatment in Indonesia, and that's why a referral letter was given to the patient to continue his wound care back in Indonesia. That is all. I think can go back to the picture just now.
Okay, Miat, do you want to comment a little bit? What do you think?
Yeah, Professor, in my country, how do you think? We are lucky or we are fortunately, we have two kind of the symptom, neurotoxics and hematotoxics. In hematotoxics, we usually present with the systemic envenoming, not with the local symptom, rather than local symptom. For the Naya species, we usually see the systemic envenoming, not the local envenoming. It's really, maybe I'm the public health person, maybe the physician, emergency physician, we can see, but most of the cases are usually present with a systemic envenoming rather than local envenoming. And that bite side, maybe York will continue the discussion. Over to you, York.
Yes, I mean, from the symptoms, this vomiting is typically for Naja envenoming. So many patients bitten by Naja species vomit. I think there's a statistic of about 1/3 present with vomiting or nausea and vomiting. Yeah? So that is one thing that the suspected bite from a Naja is maybe right. The swelling, of course, would be the second symptom which fits to a Naja bite. And the third one is also, there was in the laboratory result, there was a high white blood cell, 18,000. That is quite high for an acute in an acute situation, and that also points to 18,028 there. That points also to envenoming in this case. I'm not sure.
Leukocytosis, reactive leukocytosis.
Yeah, reactive leukocytosis due to venom. So envenoming.
Yes.
So The question is always in these cases whether antivenom makes a difference or not. So I think that is something still a little bit controversial, I would say. But of course, in a case where the swelling progresses fast, you can give antivenom, yeah, if you have enough.
Yeah, that's another thing.
So that is the reason in Laos we don't have enough. So we reserve antivenom for those cases who develop really neurotoxic signs for Naja bites. So, but I think there's no really good study that would really confirm that antivenom for local swelling is really working. So some people they say it's working, but there is no really study on this. So you can argue whether you give or give not.
Yeah. Yeah. Any input from you for this case?
Okay. I think you already discussed it adequately, and just want to know what was made. I missed the treatment part. Can you show it, please? Did they give the same treatment? So there's the tramadol. Okay, that's good. No more hydrocortisone. And yeah.
Okay. Anything else you want to comment about the management?
Oh, the anti-tetanus as well. Ask about
what about this? What about this ultrasound pulse protocol? Are you practicing it?
For us, not yet, Dr. Ka.
Okay. maybe come to Terengganu where we have our course. We will actually.
Yeah, we need more training.
So this is actually a very interesting case where just now we'll answer maybe some of the question that you asked to see whether effect on the local from antivenom. So this case shows that when we did the pulse protocol on this case, there is an improvement in the flow. There's no more retrograde flow when we do the what we call what do you call that? Pulse. There are three things that we do. One is POCUS. When we do POCUS bedside, right? So one of it is actually we look at the extent, the local tissue, and we do that serially for the RPP, and then we do the flow of this retrograde flow on using the Doppler ultrasound. So this is a bit more advanced. It's a bit more advanced, but it really helps. It shows us we can see it. We can see the difference before antivenom and after antivenom. So it works. Even in Thailand, in Taiwan, before they had a very high rate of doing fasciotomy, but after applying this method, they said that there is no really indicated anymore for fasciotomy. That one is for treatment for protobothrops, which is a pit viper with a viper bite. So because it shows in our own eyes, in live, how the situation is in the underlying tissue. So whether the antivenom work locally or not, for us, maybe not to the tissue that is already destroyed or lies from the venom, but in terms of the local other parameters like edema and so on, the pressure here, all seems to be improved after the antivenom is given. So this may lead to probably another study that we can do in the future to see from this parameter as whether it has we can use this as a measure for the relationship between antivenom, early antivenom, to the other physical signs and symptoms. Not so much towards the what do you call the established thermonecrosis. As you can see the picture just now? of the bitten area. So you can see the progression of the necrosis even after the antivenom is given, is is already established and spread, but it doesn't really reverse the necrosis. So somebody said it reduced the size of necrosis. That's not true. Just now there was a note the bone necrosis is reduced in size, which is not true. Maybe what it meant was the swelling is reduced in size. Okay. Okay. So POCUS, our pulse protocol. We will share the video later. You guys can have a look in the chat room. Okay. So this is another interesting development of on facilitating clinical management of patients from snake bite. Okay, it's another tool that we can use. Okay. Any other comments? Any other questions? Any questions?
Mention again, Dr. Carl, like
Yeah.
when they educate their in their community, so prevention, wear boots,
Yeah.
do not when you go to the forest or
Safety seeking behavior. Yeah.
safety behaviors. Yeah.
Yeah. So those are very important message that we should send out to the public, about safety seeking behavior. Yes. So it's a behavioral change. It's very tough. So to change a behavior is not easy. So it's always to have a constant, engagement with the public in various media. So once somebody has already an injury like this, it's difficult. Hopefully he will learn and tell others to wear boots in the future. Yeah. Yeah. But that's probably too late. Too late already, right? Yeah. Okay. So back to our moderators.
We have a few questions.
So one of the person asked, are the 5 vials the normal initial dose for the polyvalent antivenom use, or does it depend on presented symptoms?
Okay. So for us in Malaysia, our guideline states the neurotoxic antivenoms for both neuropolyvalent and Najacautia, the starting dose is 5 vials. So starting those 5 vials is mainly for local syndrome, local signs of envenomation. But if somebody already developed systemic envenomation, then it's 10 vials. But it is only for cobra and king cobra. For pit viper, the starting dose is 3 vials, whether somebody has coagulopathy or not. Okay, so most of the time in pit viper, we wait for the coagulopathy to occur before we give antivenom. Most of the time, we see also some pit viper bite doesn't require antivenom. So depending on what it is, the starting dose is different. The circumstances of envenoming also will determine how much antivenom you want to give. So we give empirically. We don't know how much venom goes into the body, right? We cannot ask the snake how much venom you give to Dr. Miat. We don't know if he bites Dr. Miat, and Dr. Emily may get a bit more, but yeah. So we can't do that. So what we give the antivenom is empirically, hoping that the amount is more enough to cover all the maximum amount of antivenom venom that can enter the body from that single bite. That goes to the next issue. If somebody just now got bitten many times or multiple bites, so you will expect a higher dose of venom in the body. So you probably will consider a higher dose of antivenom to give as a starting dose. So that's the way we play it. There's no really hard and fast rule about this. So this is a clinical judgment. And if you're not sure, please contact your seniors or the experts. Like us, Rex, we can help you out with that.
What about dry bite, Dr. Carl?
There's no such thing as dry bite. Dry bite means that you don't have saliva in your mouth. But this, I find that term dry bite is a bit misrepresentation, because if it is a venomous snake, it bites you and you don't have any symptoms, like systemic syndrome and so on, then you want to consider dry bite. But what I would move towards is there is some venom go in, but it's just not enough to produce any significant sign and symptoms. So if you see dry bite means not even a single molecule of venom goes into the body. So it sounds very unusual to me. But some people use it as a term of dry bite at the end when the patient has already gone through a series of observation, close serial monitoring, nothing at all that this patient presents with a sign of envenoming, whether local or systemic, and they was discharged. And at discharge, then they can put that in bracket, possible dry bite. That's my time of when I'm using dry bite anyway. But in Malaysia, we don't use dry bite anymore to document in our snake bite cases. What do you think? Do you use dry bite in Laos and Vietnam?
No, I also don't use really this term, but I say it's a venomous bite or a venomous snake without symptoms. So maybe
Yeah,
always
yes.
with minimal symptoms, maybe.
Yeah,
Usually you have some
yeah.
symptoms. You have already the bite marks.
Pain
You
and
have
so on,
maybe
right?
a little
It
bit
could
of
be,
swelling
yeah.
usually for some snakes, and
Yeah.
I would use the term a bite of a venomous snakes with minimal or no symptoms.
Yes, that's
Okay,
a bit
that's
safer. Yeah.
I think we have the last question. What is the difference between monovalent and polyvalent antivenom, and in what circumstances do we decide to give either monovalent or polyvalent antivenom?
Anybody here?
Okay.
Emily?
I think the best one to answer would be your correct me your if I'm saying saying it the right way. When you say monovalent, like for example, here in the Philippines, we only have one antivenom, and that's for the Naja philippinensis. So Philippine cobra antivenom. We only have one. So that's what we call monovalent. However, in cases when the snake is not identified, then we can use polyvalent so that it can address the envenomation that has occurred. So I think that's the way. I mean, a very simple way of putting it. And Jörg will elaborate more, and Dr. Cal as well.
Maybe Miet, what about you have antivenom in Myanmar, right? Yeah, I
Yes,
think you have developed a polyvalent or something.
No, we only have monovalent antivenom for
yeah.
the Viva bite and cobra bite. For cobra bite, we usually only have for the Naya caudia, but we have species of Naya mandaliensis is found in the middle part of Myanmar, and lately we found it in the upper part of the Myanmar. And the Naya caudia species we usually found in the southern part of Myanmar, lower part of the Myanmar. But we found some patient in the DFAT study, the Department of Foreign Affairs and Trade from the Australian Aid Project. We found the Naya caudia monovalent antivenom is a cover the Naya mandaliensis species. But we only use a monovalent antivenom because for the Viva bite, pit Viva, we don't have the antivenom, but in my country, pit Viva bite pit Viva bite are not leader in my country. That's why we only use the monovalent antivenom for the other Viva bite species. Yeah.
Yep.
Yeah,
Well,
that's why we have the monovalent antivenom for the cobra and monovalent antivenom for the Viva.
Yeah.
Sorry,
they're
I'm
still
working in
monovalent.
the office, and that's why you can hear the voices from the
No, we can
other
only
people.
hear your voice. It's okay. No
Okay.
worries. Yeah, you want to add on?
Yeah, I mean, in Thailand, we have two kinds of polyvalent antivenom. The one is for the neurotoxic snakes, covering 4 different snakes. That is a king cobra, the Naya cautia, the banded crate and the Malayan crate, so 4 neurotoxic snakes in the region. I think that this antivenom is useful also in Laos. Definitely, it's also probably useful in Cambodia and also in Vietnam, and it's used there. And you usually we had at the very beginning the case of unknown snake with neurotoxic symptoms, and especially at nighttime when there's dark, the people don't see the snake. And if there's no swelling also, and the people don't bring the crate, for example, to the hospital, I would always go for polyvalent, neuropolyvalent, which is covering 4 different kind of snakes and the main 2 crates in the region here in Southeast Asia, the banded crate and the Malayan crate. Although usually the Malayan crate bites, at least in Laos, our experience is the Malayan crate bites more often. But anyway, that is only observation. And if you don't have the snake present in the hospital brought by the patients or a clear photo, I would always go for the polyvalent, covering 4 different kind of neurotoxic snakes. And I think the Thai is doing a good job to produce polyvalent that can be used with a syndromic approach. Yeah, so the second polyvalent is the antivenom against 3 different kinds of hematotoxic snakes. That is Daboia siamensis, the green pit viper, and the Malayan pit viper. So in case you have a patient with bleeding and the patient didn't see the snake in Southeast Asian region, I think that is a good antivenom to use, a hematopolyvalent, which is working against 3 different kind of hematotoxic snakes in the region. Yeah.
Okay, so in Malaysian context is we have both because Malaysia doesn't produce antivenom, so we import all our antivenom from Thailand as well. So we have both, and we use it according to the indications for use. When like just now, the 2 cases, mostly the one case that we unidentified snake bite with neurotoxicity, we give a neuropolyvalent. But let's say for this case, it's unidentified, but we know that the features here is very typical of cobra bite. So we can always straight away use Naja or cobra antivenom for this case, even though it is unidentified. So that's from the pathognomonic feature of this, the monocrosis that we have here. Okay, yeah. So I think that's it. Any other questions?
No, I think that's it for now. And it marks the end of the case presentation. We are very thankful for all the panelists and prof because of the fruitful discussion and input for us as a medical students. I think we all also thanks to the participants. There's a lot of question in the Q&A box, but we are sorry we cannot entertain all of it because of limited time. We are very sorry. It's quite a lot. And I think we move on to the Kahoot session by Prof. Caldo.
And the champion is...
Okay. Congratulations and well done everyone for your effort. And to the winners, please reach out to any of our secretariat. For closing remarks, I would like to invite I think Dr. York can give some
Closing remarks.
Oh. Yeah, thank you very much for this nice session again. So it's always very inspiring to hear about all these cases from the real world and not only from books, and the problems we face with the daily clinical work. So these cases which are maybe reported as snake bites, but in fact they are not. So you have to really follow certain guidelines, and it's always good in certain cases to have experts to ask for, like Kaldem organized in Malaysia, the REX consultation service, that in doubt you can ask. But discussing cases, I think it's always inspiring and always a good learning for everybody. Yeah, thank you very much. I enjoyed it again, and maybe see you next time.
Right, thank you, Dr. York. I think we can invite Prof. Holden to give.
It's okay. It's
Okay,
already closing
okay.
remarks, so there's nothing for me to say.
Uh,
Okay, keep your clothes on. Selamat berbuka puasa. Happy Ramadan. Hopefully to see you in the next program, the third series. I think in May. I think, yeah, May or June.
yeah. All right.
Okay. Happy birthday again, York. Happy birthday,
Okay,
Dr. York.
thank you.
Every
Dr. York's
Bye-bye.
birthday yesterday. Okay. He looks younger every year. Yeah.
Bye-bye.
Bye-bye.
Okay.
Thank you, everybody.
Once again, thank you so much, Dr. Miat Tek Neo, Dr. York Blessman, Dr. Emily B. Santa Maria, and Associated Prof. Dr. Khaldun. It was an eye-opener to hear from the views of experts and very exciting case discussed. We hope this session will give awareness to the medical students, especially about toxinology and clinical toxinology, also increase their confidence and knowledge in how to manage toxin cases. And then we end our webinar today. And thank you. We will also put a link in the chat group chat for the participants for the feedbacks and e-certificates.